This is a white blood cell disease part 3 hematology tutorial presented by Dassi SchrDbb. Reference Global Lots of Hematology by Harald Thelm. So we are going to start here with the different myeloblastic diseases. So now, in order to know the different myeloblastic diseases, I'm going to just give you a brief summary on the different myeloblast series. You need to know that in the myeloblast series, you start with the promyeloblasts. After the promyeloblasts, you have the myeloblasts. After the myeloblasts, you have the promyelocytes. After the promyelocytes, you have the myelocytes. After you have the band cells. And after that, you have the different cells like the neutrophils, eosinophils, and basophils. Now, you need to know that what? In myeloblastic leukemia, usually the myeloblasts are the ones that are going to be predominating. And the myeloblasts do not convert to produce the different cells at the end of the series of the cycle. Is it clear? So you see that what acute myeloblastic leukemia means that what there is going to be excessive accumulation of the myeloblasts at the level of the bone marrow. Since it's excessive accumulating in the bone marrow, that is why you're going to have the pathologies early, like you are going to have low level of red blood cells because of suppression of the erythroblastic cycle. You are going to have low level of thrombocyte because of suppression of the thrombocyte cycle. You also have low level of the lymphocyte because of suppression of lymphocytosis. Is it clear? So that is why myeloblastic leukemia, which are also called myeloleukemias in this case, are acute. Is it clear? They occur very early because they are present in the bone marrow. The myeloblasts are present in the bone marrow and do not move out of the bone marrow. They stay in the bone marrow. That's it. So the next thing is to visualize the characteristics. So the age is any age. The clinical feature present with fatigue because of anemia, fever. We have fever because of the signs of tumoral process. The signs of tumoral process, you have weight loss, you have fever, constitutional symptoms, fever, weight loss, anorexia, night sweat, and all the like, and body weakness. So you have signs of hemorrhage in later stages. So the next one, you have lymph node and intestinal are typical only in acute lymphoblastic leukemia. They are not present because the myeloid pathway in the myeloblastic cells, because the neutrophils, the eosinophils, and the basophils are usually present at the level of blood and the bone marrow. Look at the two main places where they are present: neutrophils, eosinophils, and the basophils. Their precursors and themselves are present only in the bone marrow and blood. They are not present in the tissues. Is it clear? And they are not present in the lymph nodes. So generally, when you have lymphadenopathies, enlarged lymph node, you should not think of a problem involving the myeloid pathway. You should think of a problem involving the lymphoid pathway. So if you have an acute disease with lymphadenopathies, you may think now of lymphoblastic leukemia. So you may think of lymphomas. Is it clear? Involving the lymphoid pathway and not the myeloid pathway. Is it clear? So that's why they say that lymph nodes are generally not present in acute myeloblastic leukemia. Now, the full blood count and the laboratory finding: hemoglobin level is going to be low, thrombocyte level is going to be low, leukocyte level are going to be low, especially the lymphocyte. Is it clear? So the differential diagnosis, you have blood cells also in this case are going to predominate. So you can also have an excessive, in this case you can have an excessive level of uric acid. That's why you can see urate accumulation, because in this moment the urate is produced from excessive destruction of cells. Is it clear? When you have excessive destruction of cells, you can have urate accumulation. So the further diagnosis is going to be via immunocytochemistry. You can have cytochemistry, and you have bone marrow analysis, and you can have cytogenetics. May show you an acute myeloblastic leukemia. Now the next thing is leukemic non-Hodgkin lymphoma is a differential diagnosis. Aplastic anemia is a differential diagnosis. they transform myeloproliferative syndrome with chronic myeloleukemia to differential diagnosis. Myelodysplastic syndrome is a differential diagnosis. But what the question is I want to ask you is, what is myelodysplastic syndrome? Myelodysplastic syndrome actually is an increase in proliferation of all the cells in the myeloid pathway, but the proliferation is going to result to normal end cells. Are you understanding? In myelodysplastic syndrome, you have an increase in proliferation of all the cells in the myeloid pathway, but the end cells are normal. In case of a myeloid leukemia, what you're going to see in the blood are going to be myeloblasts. Is it clear? You don't have normal neutrophils, normal eosinophils, normal basophils. No, you don't have it. Is it clear? But in a myelodysplastic syndrome, you are going to, all the cells in the myeloid pathway are going to be normal. The neutrophils that you're going to see are going to be normal. The eosinophils you're going to see are going to be normal. The basophils you're going to see are going to be increased, but they are going to be normal. The red blood cells also come from the myeloid pathway in an extensive view. That's why you're going to have an excess level of red blood cells. Also, the thrombocytes come from the myeloid pathway in an extensive view. Now you're going to see the excess level of thrombocytes. That is what is called myelodysplastic syndrome. Excessive increase in all the cells of the myeloid pathway and result to the normal cells at the end of and you have normal cells inside the blood findings. That's myelodysplastic syndrome. The next one I usually associate with deletion of the long arm of chromosome 5. The next one you have leukemia. I've already said this. The cause of the therapy usually rapid progression with infection, complication, and bleeding. So you have immediate deficiency to chemotherapy. Now, the next thing to visualize now is the acute leukemia. So in this acute leukemia, you can see undifferentiated blast cells in diagram A. You have undifferentiated blast cell here. In diagram B, you have peroxidase reaction. So when you put peroxidase, how does it react? So that is how it's going to react with peroxidase reaction. So you have peroxidase reaction in diagram B. That's it. The next one is with diagram C. So with diagram C and D, you can see variant of leukemias. So these are the different variants of the leukemias. Is it clear? So those are the hour bodies. So hour bodies is seen with 2, and these are the hour bodies, and then 1 is containing granules. So those are the different cases for the first part. Now we have acute leukemia still. So we have M1 and M4. So these are still the acute leukemias. So these are the different cells that you can visualize in acute leukemia. So you can, in this case, you're going to have myeloblasts. In this case, is it clear? So diagram B, we have a type 2 M1. So you can see multiple hour bodies here. Multiple hour bodies are often stacked like firewood, so-called fagot cell. Is it clear? So then diagram D now. So in diagram D here, you can see a bone marrow cytoplasm cytology with acute myelomonocytic leukemia. Is it clear? So we have acute myelomonocytic leukemia here. And then in diagram E, diagram E, you can see other different morphologies of that. So we have what is called, you have different classifications of acute myelocytic leukemia. Acute myelocytic leukemia can exist as an acute promyelocytic leukemia. And the acute myeloid leukemia can exist as an acute promyelocytic leukemia. As I've initially told you, I've said that in the myeloid series, in order to produce the different granulocytes, you start with the myeloblast. After the myeloblast, you have the promyelocyte. After the promyelocyte, you have the myelocyte. After the myelocyte, you have the band cells with the junctional cells and all that. Is it clear? Now, in a myeloid leukemia involves all of them. In some cases, you can have acute promyelocytic leukemia, where you're going to see high level of promyelocyte. Is it clear? So in the FAPS classification, it's called type M1 and type M1V. Now the second one is acute myelomonocytic leukemia. Now we also know that in an extensive view, the monocytes are also found from the myeloid pathway. That is why you can see also an acute monocytic pathway, which is the precursor form of a monocyte. So this one is called in the FAPS classification, that's the French, American, British classification, is going to be type MA. Is it clear? So it's going to be type M4, sorry. So those are the different types. So that's acute myelomonocytic leukemia. The next acute myeloleukemia is acute monocytic leukemia, when it's involving the monocytes. Is it clear? This one is called type 5A and B. Is it clear? Type 5A and B. Now you need to know that what also sometimes I've said that what the erythrocytes also are from the myeloid pathway in an extensive view. That is why you can also have an acute erythroleukemia, and in the FAPS classification is going to be M6. Are you understanding? So those are the different. The next one, you have acute, I've said again that what the thrombocytes are also deriving from the myeloblastic pathway in an extensive view. Is it clear? So that is why when you have also thrombocytes, so you also have a myeloid leukemia corresponding to thrombocytes called an acute megakaryoblast leukemia. Is it clear? So the first one, so in summary, this is a division of the myeloid leukemia is going to be based on the different cells which are produced on the myeloid leukemia. In a pro-myelocytic leukemia, you need to know that what is going to result to the granulocytes. So that's why it's acute pro-myelocytic leukemia involve type 1 to type 3. A myelomonocytic leukemia involve the monocytes with acute monocytic leukemia. So that is myelomonocytic is type 4. And then type 5 is acute monocytic leukemia based on the FAPS classification. The next one is erythroleukemia, is it based with the erythrocyte, or acute erythroblastic leukemia with the erythrocyte. That's FAPS classification 6. And the last one, FAPS classification 7, is acute myeloblastic leukemia. Now, acute myeloid leukemia with dysplasia. So criteria for dysgranulopoiesis is greater than 50% of all segments of neutrophils have no granules. So when they want to tell you that this is an acute leukemia, acute myelocytic leukemia with dysplasia, we have different criteria. So the first one is criteria for dysgranulopoiesis. It means that what? So it is myeloid leukemia, because I've said that there are many different things involved in the myeloid pathway. It can range from erythrocytes even to monocytes, and involving also the granulocyte. So in order to know which one has a particular problem, is it clear, you have to know the criteria for the different dysplasias. Is it clear? Let's say that the granulocytes are the one having the problem. Is it clear? So you are going to have criteria for this granulopoiesis. So in the criteria for dysgranulopoiesis, you know that what this is an acute if you have a dysgranulopoiesis criteria, it means that it's an acute myeloid leukemia involving the granulocyte. If you have dyserythropoiesis, it means that what you have an acute myeloid leukemia involving the erythroblastic pathway. If you have a megakaryopoiesis, it means that you have an acute myeloid leukemia involving the thrombocyte pathway. Is it clear? So we start with the criteria for dysgranulopoiesis. In the criteria for dysgranulopoiesis, we have greater than 50% of all the segments of neutrophils have no granules. So you look on white blood cells, you see greater than 50% of neutrophils have no granules, or have very few granules, or show Bopda anomaly. Is it clear? With the peroxidase negative stain. So those are the criteria for dysgranulopoiesis. The second one is criteria for dyserythropoiesis, when you have greater than 50% of red blood cell precursor display on the following anomalies. You have karyorrhexis. Is it clear? If you have karyorrhexis that is shown. If you have megablastoid appearance, you have megablastic cells which are present in the bone marrow, or if you have more than one nucleus or nuclear fragmentation in red blood cells, you can think of a dyserythropoiesis disorder. The next one is criteria for this megakaryocytic megakaryopoiesis. If you have greater than 50% of at least 6 megakaryocytes, show the following abnormalities. So you see greater than 50% still in the bone marrow. You see the megakaryocytes show these abnormalities. What are the abnormalities it shows? It shows micro megakaryocytes. The megakaryocytes are very small, micro megakaryocytes. You have more than one separate nucleus. So you have 2 nucleus or something like that. So you have large mononuclear cells. So those are the different things that can make you think of a. So you can see large mononuclear cells, because normally what is involved with the breaking down of the megakaryocytes to the different chromosomes are the mononuclear cells which are attached at the level of the megakaryocytes. But now if you see large mononuclear cells attaching to the megakaryocytes, you can know that this is a dysplasia involving the megakaryocytic pathway. Is it clear? So we have hypoplastic. So this is a dysplasia acute myeloid leukemia, and these are the different dysplasia you may see. Now if you have a hypoplastic acute myeloid leukemia, sometimes mostly it's an leukemia. It's considered as an leukemia. WHO classifies on the FAPS of the WHO classification. The bone marrow are largely empty and show only a few blast cells. So in this case of acute myeloid leukemia, it is instead with a hypoplasia in the myeloid pathway. So that's a hypoplastic acute myeloid leukemia. So this is an example of acute myeloid leukemia with dysplasia. Is it clear? So acute myeloid leukemia with dysplasia, you see diagram A is acute myeloid leukemia with dysplasia of megaloblastoid, dysplasia of erythroblast. Is it clear? So this is a dysplasia of erythroblast. In one is dysplasia of erythroblast, you see there was karyorrhexis. There were different classifications. You see karyorrhexis, you see 2 nuclei at the level. So it is exactly. Now, and you can also see even Berger-Hertz form. So in dysplasia involving the granulocytes is 2, which shows the Berger-Hertz forms. Is it clear? And you can have greater than 50% of cells that do not have, of neutrophils do not have the granules. As you can see here, you have no granules. Now the next one is diagram C and D. So we have diagram C and D. So we also have diagram C and D. We have, in this case is hypoplastic acute myeloid leukemia, while in these 2 cases case of dysplastic. Is it clear? So for dysplastic again, we said that what for diagram B, you can see megakaryocytes. In this case, the megakaryocytes have separate nucleus. See, there are different nucleus of the megakaryocyte. There are different nucleus of megakaryocyte. And now in this case, normally megakaryocytes should be very large, but you see that the megakaryocytes in this case are not quite large as normal. And also here, this is another megakaryocyte which is not very large. And you can see also many large mononuclear cells, that is monocytes at the level of the megakaryocyte. Is it clear? So the next one is acute lymphoblastic leukemia. So I'm not going to speak about that because much here, because it has already been said. I'm just going to speak about the scores and so this is the score on the FAPS classification that you're going to have for acute lymphoblastic leukemia. And these are the different receptors involved with B lymphocyte, and these are different receptors involved with the T lymphocyte, and these are different receptors involved with the myeloid pathway. So I'm not going to speak much about that. So myelodysplasia. So let's see now what is myelodysplasia. So the myelodysplastic, the clinical practice has long been familiar with a scenario which, after years bone marrow insufficiency with more or less pronounced deficit in 3 cells. So if you have a more or in myelodysplasia, if you have a more or less pronounced deficit in all the 3 cell series, is going to be called a myelodysplasia. Is it clear? Because the 3 cell series affected are the series of granulocytes. You have the granulocyte series, you have the erythrocyte series, and you have the thrombocyte series. Is it clear? If you have an effect on all these 3 series, it's going to be called myelodysplasia. But Myelodysplastic syndrome is when they are increased. Is it clear? When you have a myelodysplastic syndrome is when they are increased. And an example of a myelodysplastic syndrome when all of them are increased is Vasquez disease, where all of them are increased, but the proportionate increase is that what the red blood cell is going to be increased much more than the other one in this particular myelodysplastic syndrome. Is it clear? So, but in myelodysplasia, you have instead dysplasia of all the three. Is it clear? So you have anemia. So you can have anemia by cytopenia. By cytopenia means that what you can have a decreased level of thrombocytes. You have decreased level of the neutrophils, and or even a tricytopenia without a cause. You can have a dyserythropenia with sometimes pronounced erythrocytes. You can have this granulocytes. You have this megakaryocytosis. So all these are present in myelodysplasia. So forms of myelodysplasia. There are different forms of myelodysplasia. You have refractory anemia in patients. So some patients have the refractory anemia which are always present. You have refractory anemia with ring sideroblasts. You have refractory anemia with excess erythroblasts and all that. These are examples of diagram with myelodysplasia. So A to D is different degree of abnormality of mature with pseudo-Berger type. It's not actually a Berger feature, but it's a pseudo-Berger type. So the nuclear density can reach that of erythroblasts. So these are the different nuclear density with the different pseudo-Berger features. Is it clear? So you see two nuclei, you see there are two nuclei, there are Berger bodies here, there is all that. So those are the classes, the different things involved in myelodysplasia. So you can also have a chronic myeloma, monocytic leukemia considered as a myelodysplasia and all that. Now, prevalence of polynuclear. So if you have now a high level of neutrophils, you can have neutrophilia without a left shift. Is it clear? So diagnostic workup of abnormalities of white cell series with polynucleated. You need to know that what these are all the clinical findings of the patient. If you want to see the clinical findings, you have to know this, and these are all of the features also involved with increased level of neutrophils. Now, what are the causes of neutrophilia? All kinds of stress can increase the level of neutrophil, because you need to know that what the neutrophils are inside the blood vessels, but they may hide on receptors inside the blood vessel, and particularly at the level of the lungs. When you are stressed, you increase your respiration, and when you are increasing your respiration, you are breaking down the bond between the neutrophil and the receptor. That's why it can cause the increased level of neutrophilia. Pregnancy is the same thing. You have to breathe faster, and you are going to, in order to compensate for the baby, and when you breathe faster, you release neutrophils. Connective tissue disease is the same thing. You don't have receptors in order to attach for neutrophils. That's why neutrophils that are present do not attach to the receptors, but are only in blood. You have tissue necrosis is the same thing. The tissue necrosis here, where every time you have necrosis in the body, you need to know that what the neutrophils are going to proliferate to that tissue in order to cause a coagulation in necrosis, and they are going to cause fibrosis at that level. They are going to phagocytize on the dead cells. Is it clear? You have acidosis of various etiologies. Is it clear? You have medication, nicotine, corticosteroid, adrenaline, digitalis, allopurinol, and all that are involved here. So if you have, so this is a non-reactive left shift. Is it clear? Now you have reactive left shift. So reactive left shift is what is that? So actually, what do we mean by left shift? That's a question that I want to ask yourself. So sorry that I did not tell you that at the beginning. Actually, a left shift is actually when there is a destruction of the neutrophils, resulting to an increased level of the neutrophil. That's why it's called left shift. Our understanding. It means that what? It means that, so it is actually, if you want to know left shift, you can just write a small arrow diagram where you write neutrophil produce on the right side of the equation, on the left side of the equation, and then you write neutrophil produce on the right of the equation, and then you write neutrophils destroyed on the left side of the equation. Is it clear? And then you draw an arrow moving from right to left. Is it clear? So a left shift is what? If you destroy more of the neutrophils, more of the neutrophils are going to be produced in order to kill what is destroying it. Example, if you kill two neutrophils, 5 neutrophils are going to be produced. So when you have, if you kill, let's say that you kill 2 neutrophils, 10 neutrophils are produced. Is it clear? So it means that when you have subtracted 2 neutrophils from blood, but you have added 10 other neutrophils, so it means that what they say, an addition of a compensatory 8 neutrophils. Is it clear? In the left shift. In case where you have a neutrophilia without left shift, you are not destroying the neutrophils. Is it clear? In all the causes that you have seen in neutrophilia without the left shift, as you can see here, stress, nicotine, pregnancy, they are not destroying the neutrophils. Is it clear? But there is an neutrophil increase. But in this case, the relative left shift neutrophils, here you are actually destroying the neutrophils. When you are destroying the neutrophils, you have a compensatory increase in the number of neutrophils. As I've taken an example, you destroy 2, you have 10, you have a compensatory increase of 8 neutrophils. So this is an examples of reactive left shift neutrophilia. So we have left shift occur regularly. So example, in case of bacterial infection like the Myelody, tuberculosis, destroy but you are producing more. You have non-bacterial inflammation like colitis, pancreatitis, even appendicitis, phlebitis are involved. You have cell breakdown like burns, liver failure, hemolysis. Now left shift now sometimes occur in case of infection like with fungi, with viruses, myocardial infarction, pulmonary infarction, metabolic changes. You have phases of compensation and recuperation. So all this is involved here. So these are the cases of the left shift. You see that the neutrophils are going to be quite normal, so you have no problem with the neutrophils. You just have an increase in neutrophils in the cells, in the blood. Now the next thing to visualize is the chronic myeloid leukemia. Is it clear? It's also called chronic myeloproliferative disorders. So in chronic myeloid leukemia, so these are the different things involved here. So these are the chronic myeloid leukemia. You need to know that what all the series of the myeloid pathway is still involved in chronic myeloid leukemia. But what is nice with chronic myeloid leukemia is that what, though the cells of the myeloid pathway like stay inside the bone marrow, they are going to move out. Some are going to move out from the bone marrow into blood. Is it clear? And that's why it is going to be of chronic form. They will not stay in the bone marrow to directly express the disorder on other the blood cells. That's called chronic myeloid leukemia. So now we need to know that the clinical characteristic and differential diagnosis criteria of chronic myeloproliferative disease. So in this case, you can have splenomegaly in myeloproliferative disease. You have changes in full blood count. You have leukocytosis with left shift, eosinophilia, basophilia. Is it clear? So we have thrombocytopenia is high. So thrombocytes are high in the myeloid pathway. You have bone marrow cytology is very cellular with basophilia, megakaryocytes, eosinophils. Bone marrow histology, granulocytes, and all that is involved. Now the Philadelphia chromosome is very involved with chronic myeloid leukemia. So when you are talking about chronic myeloid leukemia, the chromosome you should think of is Philadelphia chromosome. Now, what are the chromosomal abnormalities in chronic myeloid leukemia? The chronic myeloid leukemia, you have blast criteria. You have this blast criteria. Now, the next one is alkaline leukocyte phosphatase is low, and then vitamin B12. So these are the characteristics. So what is the characteristic of chronic myeloid leukemia? Said at any age, usually the incidence is about 50 years. Slowly developing fatigue, anemia, and all that. You have leukocytosis and a left sheet of granulocyte. Is it clear? You have an increased level of leukocyte and you have a left shift. Why? Because those leukocytes die, but you have a compensatory increase in those leukocytes. Anytime you have an infection and that leukocyte die, compensatory increase with the leukocyte. So the diagnostic criteria, see the bone marrow, the cytogenetics, the molecular genetics, in order to see the Philadelphia chromosome. Is it clear? Now you have differential diagnosis. You have reactive leukocytosis, alkaline phosphatase. You have other myeloproliferative diseases. Now, how do you treat the chronic progression? Acute transformation of that chronic disease may occur. Is it clear? So what are the steps in the diagnosis of this? So you need to know the diagram. So in the diagram of chronic myeloid leukemia, so then the analysis, you have chronic myeloid leukemia, you have segmented neutrophilic granulocyte. You can see segmented neutrophilic granulocytes here. In diagram 1 is segmented neutrophilic granulocytes. Diagram 2 it shows a band cell. So band granulocyte. So diagram 3 shows defective myelocyte, and diagram 4 show myelocyte with defective granulation. So normally the myelocyte are not supposed to have granulations, but in this case you see myelocyte with granulations inside, so it's not quite correct. So diagram B and C, so you can see myeloblasts in diagram 1. Diagram 2, you see also granulations here. It's not normal. So these are pro-myelocyte with granulation. It's not normal. So myelocyte with granulation can also be seen in diagram 3, which is not normal. So diagram 5, we have granules and large dark, so a nuclear chromatin in pro-myelocyte, which is not normal. So it should not see granules at the level of pro-myelocyte and myelocyte. When you see granules like that, you may think of a chronic myeloid leukemia involving the myelocytic pathway, involving the pro-myelocytic pathway. Sorry. So this is another bone marrow. There is a bone marrow diagram now. So in the bone marrow, we still have all what we have seen just above there. Now we have blast crisis in chronic myeloid leukemia. So this is the diagram for acute blast crisis in chronic myeloid leukemia. You can see myeloid. So the blast crisis means that what excessive blasts are going to be located in, are going to be released inside the blood, because the myeloblasts are going to increase in number. So that those are the blast crises. You can see the first diagram A will show you one. So this is a myeloblast with somewhat atypical lobes. Normally myeloblast should not have lobes, but this one has lobes. You have a basophilic granulocyte inside the bone marrow. You have precede blast crisis. So all these precede blast crisis. So diagram B now, you have myeloblasts in the acute chronic myeloid, so acute chronic myelocytic leukemia, where blast crisis. Normally, so we are talking about a blast crisis. It is an acute form of a chronic myeloid leukemia. So acute, you have excessive secretion of the myeloblast in a chronic myeloid leukemia. That's called a blast crisis. So it's an acute form of a chronic myeloid leukemia. So the chronic myeloid leukemia already exists because the patient has a Philadelphia chromosome, but he has acute crisis. Is it clear? So typical SAN. So you have also another one which is typical SAN chromatin structure. As you can see here, you can see typical SAN chromatin structures located at the level of the crisis. Now the last diagram here, which is diagram C, the bone marrow cytology of acute chronic myeloblastic leukemia blast crisis, the variable signs of hyperlocated megakaryocyte. Now the next disorder is osteomyelosclerosis. Is it clear? So osteomyelosclerosis, when anemia accompanied by moderately elevated leukocyte count, thrombocytopenia, and thrombocytosis. Here you see that what you see that you have an elevated, only the pro-myelocytic pathway is elevated. Is it clear? It's not all the myelodysplasia that occur. There's only a particular myelodysplasia, which is the pro-myelocytic myelodysplasia. Is it clear? So if you have a pro-myelocytic myelodysplasia, it's going to increase in number and then cause a deficiency in other myeloid pathway like the erythrocyte and the leukocyte, causing a low level of leukocyte and causing a low level of the thrombocyte. Is it clear? It's causing low level of the erythrocyte, causing a low level of thrombocyte. So when it causes both of those low levels, it's going to cause now a fibrosis of the bone marrow. That's why it's called osteomyelosclerosis. Sclerosis for rigidity of the bone marrow, and that rigidity usually comes from connective tissue. Now, What are the characteristics of osteomyelosclerosis? You have age of concept, usually older than 50 years. So when people are very old, you can have osteomyelitic that. You have signs of anemia, skin irritation. Why? Because there is excessive breakdown of red blood cells. Hemoglobin is going to be produced, and that hemoglobin, you are going to have bile salt that is going to be produced, going to accumulate at the level of the skin. Also, the uric acid with uremia formation also accumulating in the skin could cause irritation, that's called scratching. So you have usually you have thrombocytopenia, you have normal blast, and you have the left shift. The further down, you have fibrous bone marrow. When you see fibrous bone marrow, you can think of that's what makes you to think of a myelosclerosis, osteomyelosclerosis. When appropriate, differential diagnosis splenomegaly in cases of lymphoadenoma or other myeloproliferative disease, myelofibrosis in patients with metastatic tumors or inflammation, absence of splenomegaly. So those are the different cases. So what are osteomyelosclerosis findings? So in diagram A, we are screening the blood. So when you see the blood, you see red blood cell precursor, autochromic erythroblast, basophil erythroblast can be seen. These are autochromic erythroblasts here, basophilic erythroblasts here. So these are the different erythroblasts. But in diagram C, sometimes small dense megakaryocyte can be seen in blood. This is not normal. You cannot see megakaryocyte in blood. When you see megakaryocyte in blood, is abnormal. So you can see megakaryocyte in blood. Also, you see that the cells or the red blood cells are also malformed normally. So in osteomyelosclerosis, there is so much low level of platelets, low level of red blood cells that the red blood cells are becoming malformed. You can see teardrop cells here. As you can see malformed red blood cells here. You can see even megakaryocytes entering, small megakaryocytes entering the circulation, and you can see also other small monocytes entering into the circulation. All that make you think of osteomyelosclerosis. Now, what are the diseases involved with elevated level of basophil and the strong eosinophil count? Now, you need to know that what there's a disease, a worm called Strongyloides stercolis in particular, causes a strong and sometimes extreme elevation of eosinophil, because eosinophil is for parasitic infection. Mostly, what are parasites? Parasites are protozoan infection and worm infection. So particularly in Strongyloides stercolis infection, that is going to increase high level of eosinophil up to 50%. However, eosinophil is variably seen in amoeba like protozoan, that's a protozoan infection. In giardiasis, it can also be seen in schistosomiasis, in filariasis, and even malaria. So in malaria is what is a parasite and not a bacteria. That's why. So malaria is a protozoan, trophozoite and all that. Plasmodium is a protozoan. That's why eosinophils are more in malaria. Now the next one is in elevated basophil count. So the elevated basophil count is so you can see it in especially you can have drug diseases. You can see allergic reaction, particularly to food. You have drugs, you have parasitic infection like filaria, and you have schistosomia. It's going to cause an elevated. Also other cases like in basophilia, you have tuberculosis and chicken pox. So this now is going to be involved now with the eosinophilia and basophilia. So the screening view of blood with reactive eosinophilia and eosinophilic granulocytes is scanned. So page 1 year shows that what you normally eosinophils have a 2-lobe nucleus, and you have also many granules, pink granules inside. That's eosinophil 8. So this is going to be much inside circulation. Basophilia also a 2-lobe nucleus, and you have eosinophilic granules or basophilic granules. Is it clear? Now you have segmented neutrophils. So the next one is diagram B and C. The image show eosinophilic granules in diagram B and C. You have eosinophilic granules. You can also see basophilic granules here in multi-lobe. Now diagram so C, B and C here. Eosinophilic granule. Now the next one is diagram D, bone marrow. In the bone marrow here is a systemic mastocytosis. Is it clear? You have tissue mast cells. So mastocytosis, tissue mast cells are going to be increased. So it's also another cause why you can have a bastophilia. You have mastocytosis. Now from here you have finished. You have finished with the major diseases involved with the granulocytes pathway. So you have childhood. So you have clinical pictures on disease. You have localized mastocytosis. You have urticaria pigmentosa. You have systemic mastocytosis, malignant mastocytosis, and acute mast cells leukemia. All these are the different form of benign and malignant form of tissue mast cells disease. Why we did not speak about mast cells directly, but you need to know that what mast cells are older cells also still coming from the promyelocytic pathway, and these are the different diseases involved with the mast cells. We said localized mastocytosis. You can say you urticaria pigmentosa because it's involved with release of heparin and all that. We have systemic mastocytosis. We have malignant mastocytosis and acute mast cell leukemia, and these are the different characteristics which are involved with the different mastocytosis. Is it clear? So from here we say thanks for your kind attention. Please don't forget to like and subscribe for our channel Science Video Makers. Thanks very much.